going on, podcasting world? Welcome back to another episode of the Core Consult RX podcast. Cole is not with me today because we had to reschedule our recording day, and so in his stead, I have our longtime friend, Dr. Brian Gilbert. Brian, what's up, man? Good to have you back on the show.
I know, it's been a while. Thanks for having me back, man. I was starting to think that you guys have forgotten about me, but I'm glad to scratch the old Core Consult RX itch here. I like it.
There you go. Now, what happened was you had such a lead on everybody else as far as guests that we felt it was better for them to let them try to catch up so that, you weren't stealing the show. But
I was texting my wife and trying to figure out if this is like the 5th, 6th, 7th time. It feels like I got to be getting close to double digits.
I was just going to say, I think it's 6th, but I'd have to double check myself. But yeah, man, you've been one of our longest returning guests. So welcome back, man. How's life been? What's new? Anything good happening?
Just living it. Yeah, man. Just we're slowly, getting past this the old pandy, and hospital life is starting to seem a little bit more normal here lately. So we're in the thick of having new residents, getting them trained up, and hit the reset button a few weeks ago, and just regrinding on everything. So trying to prepare for mid-year, try to prepare for ACCP and all that fun stuff.
And are you still leading the residency program where you're at?
I am I'm still the PGY2 critical care director. Absolutely. Still in the emergency department, and going on my 8th or 9th year, something like that. So it's crazy to think.
It is nuts. Because when did you graduate pharm school? 2015?
Yeah, we were both 2015, I think, right?
Yeah, I was too. It's crazy because I was thinking about it the other day. I'm like, how long have I, been licensed and everything? I'm like, it's going on. Oh, it's almost 10 years. Jeez.
A decade. Yep.
That's not good.
Did you and your classmates come up with like a 10 or 20 year reunion thing that you're going to do? Because I know that my classmates at the University of Florida in Jacksonville, we definitely have a 20-year plan.
No, well, if there is one, I'm not real aware of it.
We'll invite you to ours. That's fine. Don't worry about it.
That's perfect. I'm coming. I'll be like, what do you mean you guys don't remember me? I'll just keep asking.
Yeah, I was in the back.
Tell me their name. That's the way my real class reunion would be. They'd be like, who the heck is this guy? You just tell me people's names ahead of time, and I'll just walk up to him casually and go, oh, Eric, what's up, man? It's great to see you. He's like, who the heck? That'd be awesome.
This is Mikey C. He's got like 30,000 followers on the gram now.
Yeah. So everybody else is doing other things that matter, and he's fooling around on Instagram. But,
oh gosh,
man. So what are we going to be talking about tonight? Because I think this is a topic that I don't believe that we've really touched on at all. If we have, it's been barely anything. So what are we going to be talking about?
Yeah. I was when we linked up, I started thinking about like the topics that you and I have done together, and started just scrolling and making sure and looking through all the past episodes. And I agree with you. I did not think I had heard it before, but just a quick overview of acute ischemic stroke, and then there's sort of been a paradigm shift here recently in the past, I would say 2-3 years now. We're going on where we're switching agents that we've traditionally used for stroke management in terms of our thrombolytics, which is one of our mainstays of pharmacotherapy for acute ischemic stroke management. So we switched thrombolytics from Alteplase to Tenecteplase. And so we're going to discuss a little bit about just a brief overview of stroke, my thoughts on that, and then we'll discuss Alteplase versus Tenecteplase.
I like it. I'm going to be taking notes on my end too, so I can learn something too.
Yeah, it's super interesting. This is definitely when you talk about these two drugs in the comparison, this is where the kinetics and dynamics of the drug really do sort of hit home, and you start to wonder, when you're in your kinetics and dynamics class, like why do I ever have to know this? Well, this is a good topic for that. So, in terms of breaking down this topic, I think the first thing to understand is just like, patients that come into the ER or are out in the field or EMS and have signs and symptoms consistent with stroke, one of the things that you'll always hear is time is brain. Now, we certainly understand that it's a relative process in terms of neurons that are lost with the amount of ischemia that occurs. But essentially, when you think about stroke or time is brain, you can break it down by an ischemic event or hemorrhagic event. So the majority of strokes that we see in the ER or that we're going to treat are going to be ischemic. I think last time I saw the data and epidemiological data, it's about 90% is ischemic, 10% hemorrhagic. So basically either having a clot in the vessel or the vessel itself is bleeding and you're having blood within the parenchyma. So those are the two that we are going to manage, and you certainly they're different. And for tonight's talk, we'll basically be discussing the ischemic portion of stroke management because we could have a whole another topic on hemorrhagic stroke. And so maybe in like 2 years or a year or whatever, when we get everybody else caught back up for number 7, I'll come back and do that one.
Sounds good, man.
Yeah. So you're basically like the first thing we need to do is try to identify, is this patient having a stroke? And it's really difficult because obviously there's not really a lab test that's really great at it. And there's not like imaging that is really great at identifying it early. Everything that we're talking about in this setting is definitely a time sensitive process. And so you're really trying to figure out, could this be other things at first, and then if it can't be other things, almost a diagnosis of exclusion, you're saying, okay, this patient's probably likely having a stroke and we need to act on it. So one of the acronyms that we like to use and look for in terms of signs of stroke is the BFAST, which oftentimes you'll see within the EMS realm. And so BFAST basically means for the B stands for balance, E is for eyes, F means face, A it means arms, and then S stands for speech, and then T means time. Basically, time is of the essence. So when we say we're trying to work quickly, BFAST is the acronym that we'll use. So if it's in the EMS setting, we'll get an alert from our EMS colleagues to let us know that, hey, we think this patient may potentially be having a stroke. And they have different scales and different validated tools that we don't really get discuss in terms of the likelihood of having a stroke or potentially having and identifying where that lesion or the clot may be. They have different scales, but as a pharmacist, I'm just listening out for the keywords of, this is a patient that we think has these symptoms and they're coming in. The next thing to think about is that when we discuss this, we are saying that this process that's happening is basically a clot within the vessels. So, one of the things that we can do as pharmacy is give a very powerful clot busting medication, which is our class of thrombolytics known as TPAs or tissue plasminogen activators. Now, the way that these agents were studied was basically up to a certain time point. There is still benefit and then potentially harm if you cross that threshold. And so, our key FDA approval is only up to 3 hours, but there's some data that we can actually go beyond that, up to 4.5 safely. And even more so when we talk about some of the line shifts in stroke data. One of the things that we've seen is certainly time is of the essence, but we also want to make sure that the tissue that is ischemic that we're going to try to reperfuse and break down the clot is still salvageable. So you may hear that a lot in the stroke literature as well. So that's one big key thing to think about. Is do we think we have salvageable tissue? And that salvageable tissue that's surrounding the ischemic area is known as the penumbra. So it's a really cool pet name if anybody wants to do that. So that's what we're trying to do. Once those neurons that are basically having that ischemic event, those will die. Those neurons are never going to come back. But we still have so much innervation within the neurovasculature to save other portions of the brain. And that's all we're trying to do and optimize. So some things that you may consider or think about is, these patients, likely have very high blood pressures at first. And it makes sense when you think about it mechanistically, because these patients have a clot within the vasculature and they're still trying to perfuse the area. So you may see some of their blood pressures begin to increase. And this is all secondary to what's known as autoregulation or autoregulatory curves. So you may see that with other organs, and it's definitely no different with the brain. So we try to do that. So blood pressure management is certainly something pharmacists do, and probably outside of the scope of this talk, but that's certainly something I think about as well. But when we get down to the nitty gritty, we think about thrombolytics as a powerful clot busting medication. There's certainly things that we need to consider. And as a clot busting medication, the number one thing that I want to make sure that I do is I want to break down that clot, but I don't want to break down so much clot that the patient's going to bleed. And so the number one thing that we're going to be out with the use of these medications is going to be essentially bleeding, and particularly bleeding into the brain. And so with that, since these medications are high risk and they have the capability of causing such deleterious side effects, we have a checklist basically of patients that can and cannot get it. And so some of those like contraindications or checklists that we use are obviously any recent bleeding, any previous history of bleeding into the brain, are the patients on any oral anticoagulants outpatient, so warfarin and factor Xa inhibitors, things like that. Usually exclude patients from receiving it. There's some other relative and absolute contraindications that, again, overall stroke management's probably outside of the scope of this discussion, but ultimately that's what we're trying to do is when we exclude patients from receiving these drugs, it's mainly to those are patients at highest risk for bleeding. So you're all geared up, and as a pharmacist, you're ready to go. You start prepping, and you get the go ahead of, all right, we're going to give thrombolytics to these patients. So really, the whole core topic of this discussion is like, which thrombolytics should I use? And that's sort of been the discussion that major stroke centers like ours and others throughout the country have been having here recently. And that's our two options that we're going to discuss tonight is basically Alteplase, which has been around since the mid-90s, and then Tenecteplase, which has been approved since, I think it was early 2000. So Alteplase, which you may have heard of, or Activase, it's again, the way that it's going to act is basically going to bind and be your gas pedal for your endogenous TPA that you have. It's going to help promote clot breakdown by activating plasmin to plasminogen and then breaking down fibrinogen or fibrin into fibrinogen little subsets. And so that's also how TNK works as well. So it's pretty interesting. And so when you have a comparison or whenever you're doing these types of talks, when you think about a drug class itself or like which one should I use, I really keep it simple. I think about the efficacies of the drugs, the safety of the drugs, operational considerations of the drug, and then potentially any cost savings associated with it. So, when we start to look at the two agents themselves, in terms of efficacy, we've had major studies that have essentially looked at this, and we're starting to get more and more data that states that TNK is really non-inferior to Alteplase, which has been our standard of care since the mid-90s, in terms of our ability to give this drug to patients with stroke and have good neurological outcomes. And why is that, right? So, like, why is it non-inferior? I have I certainly have some thoughts on it that's not really substantiated or has a ton of data behind it. But, one of the things I think about when comparing the drugs is the structure of the drug and the way that it's modified. So TNK basically has been modified to be resistant to our brake pedal that's within our body to the thing that's going to deactivate our natural TPAs. And that's called your plasminogen activator inhibitors. So it's really resistant to that, your brake pedal, which is good when you have somebody that's got a big clot. You want to make sure that there's not a something that's you're gonna give it and then it's gonna deactivate. So that's one way it's pretty interesting. The other is that the TNK itself is very fibrin specific. So most of these patients too that are going to have stroke-like symptoms, potentially you're going to have older clots that are very fibrin rich. And so, giving TNK in this situation makes a lot of sense because it's going to be more specific than Alteplase, and it's going to help break down those older clots a little bit better than maybe Alteplase as well. Now, the data doesn't quite show that, in terms of the efficacy, in terms of the good neurological outcomes, they're about the same. But overall, if you were to ask me based on that, based on the way that the drug is structured, I would want to go ahead and give TNK in that case.
Does the data not show that because because of the patient populations that they've selected to be more on the safe side, so to speak, or is it just it doesn't show it because they've looked at it and it doesn't play out clinically?
So selection bias certainly has it's certainly a factor there. That's a good point. Now I will say there has been superiority data in terms of large vessel occlusions with Tenecteplase, but the amount of LVOs, as we call them, that you see within the clinical practice doesn't make up the majority or subset of patients that have strokes, right? So it's always, that's just a minor subset. So the totality of the data is that they're about the same, but if you do have that's a good point. If you do have a large vessel occlusion, TNK is absolutely going to work better. And the reason being is that when you have a very large vessel occlusion within the vasculature, there's more endogenous plasminogen activator inhibitor around that site, PAI, and those LVOs are going to be very much more fibrin specific. So it does make sense in that setting. Additionally, the thing that we haven't really discussed yet too is the ability to go in and actually aspirate or perform a thrombectomy on the stroke itself as well. So the thrombectomy is basically going in there and clot retrieving. And so, the combination of the two as well has been shown to be superior with thrombectomy and TNK in comparison to thrombectomy and Alteplase. But yeah, no, that's a good. Anytime you're looking at any of these stroke-like data, that's certainly something to consider. Is that selection bias.
Well, and I wanted to go back real quick too, because you had mentioned managing the blood pressure. In order to be a candidate to receive either agent, what is the blood pressure cutoff? Because is it still 185? Is that?
Yeah, no, that's a good point. Yeah, I didn't know how far you wanted to. I can go down all these rabbit holes for sure.
Oh man, we don't have any kind of rhyme or reason in this show.
Blood pressure management, yeah. So the reason that we want to manage it when you're giving a thrombolytic. So the thing to think about is if you're having an acute ischemic stroke, we do allow what we call permissive hypertension at first. But if you're going to receive a thrombolytic, we do try to tightly manage those blood pressures because patients that have escalated blood pressures are at higher risk for the development of bleeding into the brain, and which is obviously going to be a huge risk, and we don't want to have that. So yeah, when you give before you give the dose, either one, the blood pressure goal is 185 over 110, and then afterwards for the first hour, it's going to be, or actually the 24 hours, whatever you want to do. You're going to have strict tight management. It's going to be 180 over 105. So yeah, in those settings, I'm grabbing labetalol, IV labetalol. I'm grabbing nicardipine drips, whatever I can in that situation. I try to avoid IV hydralazine just due to sporadic onset. There's some pretty bad data with IV hydralazine, so I try to avoid it as much as possible. But yeah, no, that's a good point. glucose management as well. Don't want anybody that's super hyperglycemic because that's associated with poor neurological outcomes as well. But yeah, let's see. What the other things to think about, or the other thing I was going to bring up too about the modification of the TNK itself, like it's basically a protein and acts that way. So these really smart people, pharmacologists, have modified the structure of it, the protein or the entire structure, to allow it to be more fibrin specific, to be more resistant. And the other thing about it that's interesting is that it also has a longer terminal half-life. So Alteplase, the way that we give it and the way that we dose it is 0.9 milligrams per kilo. We max it out at 90 milligrams. We give the first 10% of that dose over 1 minute. And then we give the remaining over 59 minutes, but basically an hour. TNK, since it has a longer terminal half-life because of the modifications, is an IV push. So you actually reconstitute it and then give that sucker over 3 seconds. So obviously some operational advantages there. But, one of the things that we worry about in the setting is obviously if a patient's going to bleed or if they have, very bad blood pressure control, is if I have an Alteplase drip, I can kind of maybe pause that drip and try to get everything under control if I think that the patient's going to bleed, or if they just bleed spontaneously during the infusion, I can shut it off. Whereas with like TNK, I push it, I can't get it back. So certainly some things to consider and worry about in that setting as well.
So have they looked at like data looking at comparing like more uncontrolled blood pressure versus lower blood pressure at baseline to see if the TNK has better efficacy in that lower blood pressure group?
There's not been like any subgroup analysis that I've looked at that look at basically patients that have chronic hypertension versus those that don't. But overall, the patients that have better blood pressure control when they come in are going to, in an outpatient setting, are going to tend to do better than the patients that don't, because those vessels become friable over time. That much shear pressure makes them more susceptible to rupture and then bleeding later on. So that's why, having good outpatient management of blood pressure is so crucial, and one of the we call modifiable risk factors for the development of stroke, and that's being one of the risk factors. And the other thing to think about too, with that high of a blood pressure and causing all that shear pressure, it's going to cause all kinds of inflammation as well. So not to sound like one of those like hippie guru guys, but like inflammation is just so vital to the body. Like having all of that extra stress, cortisol, and all of that is it's just so detrimental, especially as I'm getting older too. Like everything's creaking and cracking. Like
so much.
Having my bedside NSAIDs is like just been vital for me. But yeah, no, I mean that would be an interesting study though, Mike. I think, and you talk about selection bias, is would one agent be better with those that don't have tight blood pressure control outpatient versus it would be so hard to randomize up front. Mm-hmm. You'd have to almost do it retrospectively, but certainly a good topic.
What would you guess would be the outcome? Would you think there would be a difference when you boil it down to blood pressure at baseline? I'm just curious.
I would say that like the patients that have poor blood pressure control at baseline are definitely going to they're going to bleed more. They're going to have worse outcomes overall, just probably because they're not healthier, as it is. So, and I would suspect that patients that have tighter control at baseline are going to do better, just overall. Again, due to all those things of other peripheral organ damage besides, brain ischemia. So.
But do you think there would be a difference between the two agents themselves in that case? Like if
probably not. I mean, maybe potentially. I don't know. It certainly would be an interesting study. I think that you would have to have a very large sample size that I don't think many people would pay for in a randomized study. But yeah, no, it would be interesting. I don't think you'd see much of a difference overall, but certainly in efficacy, but maybe over safety you potentially could because of again the friability of that tissue, which like it's a good leadway into safety. So like in terms of safety data, overall when we think about detrimental or like sort of the worst outcomes that we can have when we give this would be the bleeding into the brain, which primarily occurs roughly 3 to 6% of the time when we administer these medications, this class of medications. And in terms of overall safety for that, TNK and Alteplase, again, have been relatively similar. There has been some different dosing schemes associated with TNK. The way that we dose TNK is 0.25 milligrams per kilo, and then we max that out at 25 milligrams. There has been some data that's looked at 0.4 milligrams per kilo, max of 40. And there's been some consistent data now to show that like the 0.4 milligram per kilo is actually associated with higher rates of intracranial bleeding with its use. So 0.25 kind of seems to be the sweet spot. And I say the sweet spot because there's actually been dosing that's looked at really small doses, 0.1 milligram per kilo and max at 10. And it's not as efficacious. So 0.1 is too little, 0.4 is too much, 0.25, again, right in that sweet spot of where we get both efficacy and safety data, very similar to Alteplase. The other things to think about with these agents in these classes is how you manage the bleed afterwards. I will say that there was very little data on how to manage the bleed of Alteplase, and that had been around since 1996. There's even less data on how to manage the bleed with TNK, and for the most part, most people say, well, it's the same class, it works the same, and everything else is relatively the same. But we go back to those modifiable or the modification of the TNK itself and the structure. Could it potentially be? Could there be differences in how we manage that? And so certainly we don't have enough data to support that yet. Other things to think about is that these agents can cause angioedema. These agents can also, and that's probably like your second worst outcome after brain bleeding or any type of bleeding, but brain bleeding is the angioedema as well. So people don't know how to really treat that or manage that yet either. Honestly, there's been so few cases of reported TNK angioedema that we're kind of lost and not really sure what to do on that as well. So certainly an issue, and certainly something that's hopefully we can get more data in the subsequent years, or at least some expert opinions on how to manage it.
I was just going to ask have you noticed any like difference, like expert opinions as far as in actual clinical practice and how people handle that? Like, have you seen them having to use a different treatment option for bleeding from one agent over the other?
I have not had a bleeding case yet with TNK. I know that with all our Alteplase bleeds, the way that we managed it is, and this is where the abbreviations can be kind of interesting. So TNK and Alteplase are TPAs, tissue plasminogen activators, and so the absolute reverse of that is tranexamic acid, or TXA, and so you stop or X the bleed, and so the interesting part about that is TXA is used to promote clot formation or hemostasis, but we just had a patient that we gave this thrombolytic to because they had an inappropriate clot formation. And so that's something that my group here has been really cognizant of is not just giving that sort of empirically without evidence that the patient has ongoing clot breakdown. So we use like viscoelastic testing to try to identify patients that may benefit from TXA in that setting so that we can prevent the bleed from expanding, but also not just giving inappropriate hemostasis agents to somebody that may potentially clot later on inappropriately.
Gotcha. So you could basically have an ischemic stroke, cause a hemorrhage because of the drug, and then they end up having another ischemic event down just soon after. Is that how it would play out?
Yeah, I mean, it could potentially happen like that, but at that point, it's like donezo.
Gotcha.
Yeah, if you have a what we call symptomatic intracranial hemorrhage post thrombolytic, you could flip a coin. Mortality is like 50% at that point. So it's catastrophic. Selection criteria and hematoma or intracranial hemorrhage mitigation is so huge. And that's why some people are super worried about doing T&K because, at this point you're going to give it and you can't get it back in case the patient, for whatever reason, started bleeding. Now that's always a good question of like when I give this thrombolytic, like when do patients bleed? It seems like an obvious kind of question since you're worried about, could I stop the infusion? Could I not? And typically what you find in the data is that the majority of symptomatic intracranial hemorrhages post thrombolytics occur within 4 to 8 hours after infusion. Now there's been some reports that it happens up to 24 hours. These agents have short terminal half-lives. Alteplase half-life is like 3 minutes. T&K's half-life is like 20 minutes, but it has reported ongoing hyperfibrinolysis or clot breakdown. And so you don't really see bleeds like right away. Or if you do, they were going to bleed anyway, right? Regardless of the drug. Very, very little, it has very little to do with the drug at that point if they bleed like that quickly.
So really doing a push versus a 1 hour infusion, it's really not going to make too much of it, or shouldn't make too much of a difference anyway.
That was our argument for it. We had we had some discussions with some of our stroke leaders here with that concern, and that's what we discussed. We really did show the data here, and that's what we typically see is that 4 to 8 hours. And so operationally, it just made so much more sense to do it with the push. It's so much when in a busy ER that's understaffed, like we are, like a lot of ERs are. Any way that we can become more efficient or operationally sound or lean is certainly something that many pharmacy programs or even just stroke programs are looking to do. Because again, when we start talking about like time is brain, again, the longer we wait to administer or are preventing perfusion to that area, neurons are dying.
Yeah, that definitely makes sense, especially like you said, with the understaffing issues and things. And of course, it's happening everywhere, but it definitely feels like it seems to be more prevalent with critical care, emergency medicine, which is, just what we need. The most dire situations, we want to make sure those are the graveyard shit, the skeleton crew.
It's tough, and that's certainly been a focus of a focus of ours is trying to find those operational efficiencies. And like you said, we don't want to cut corners either. Like you vet all these projects to make sure that you're not going to cause harm to patients. But the other thing that was, so like when we looked on paper, efficacy wise, T&K is as good, if not maybe slightly better with like LVOs, obviously. So the totality of evidence says that at minimum, it's no worse. Safety wise, the totality of evidence says that it doesn't cause bleeds or massive ADEs or adverse drug events any worse than Alteplase. Operationally, it's better. And then we hit the last kicker, which was cost. So like overall, T&K was actually slightly less expensive, which you can't really say for a lot of times when you're talking about medicine overall, is that having a product that is maybe slightly better, safe, and operationally better, being cheaper is usually not words that rumble together often in the pharmacy department. So it made a lot of sense for us to do that. The interesting fact about Alteplase and Tenecteplase is that they're both made by the same manufacturer, Genentech. So a lot of people are kind of not concerned, but they're just kind of waiting to see like what Genentech will do. My personal opinion is that they don't really have much financial incentive to try to go for an FDA approval of stroke and things like that. So it's certainly interesting.
But there's no chance that they would discontinue one of them and not the other, though,
Oh,
right?
no.
Okay, I was going to say.
Yeah, I guess I should go back to so safety-wise, another thing to consider, or operationally, another thing to consider is that there's not a ton of data. There's a lot of good data with Tenecteplase and myocardial infarctions. Same thing with Alteplase. There's good data with myocardial infarctions. Not unfortunately, but fortunately, PCI data is just that much better than the thrombolytics. But there's really not much data on the use of Tenecteplase for like pulmonary embolisms. And then also catheter-directed thrombolysis. There's not a ton of data with Tenecteplase. So you're kind of stuck as a pharmacy director or formulary manager to try to decide, do I only have Tenecteplase on formulary for these indications where there's not like a ton of data? I'm just assuming it's a drug class type thing. Or do you have Alteplase and Tenecteplase both on formulary, but then run the risk of potentially having errors with issues or with multiple agents? The other thing to think about too, I guess, safety-wise and operationally wise, is that, and I can't believe this is why I need to write it down, man. It's all coming back to me here. Is that Tenecteplase itself is only FDA approved for myocardial infarction. So the box, which maybe you can put it on the gram, a picture of the box, actually has a flip open type box that has dosing for myocardial infarction. So it's like a huge red flag if you're going to be doing, and it's different than stroke. The dosing is different than stroke. So the T&K box and the T&K vial actually comes in 50 milligrams, but we only go to a max of 25 for stroke. So one of the things we tried to do to mitigate that, to try to prevent any adverse events, is we actually removed the drug from the box and put it into like this little built-in kit that has our stroke dosing and has our different diluents to dilute it, syringes and all that, so that we could try to mitigate some of that. That's a huge. I can't believe I almost missed that. Some ops director would be listening to this and be like screaming at me if I hadn't mentioned it. So, it's certainly. Yeah.
I like that you assume that ops directors are listening to my podcast. That's the funny part.
I assume everyone's listening to your podcast at all times.
I don't think so, but I appreciate the vote of confidence, though.
Yeah, no, I mean, there's like a lot of considerations, and certainly and that was one of the things that we did recently, was we actually like kind of put together a cheat sheet on how to like go about transitioning from Alteplase to Tenecteplase and sort of all these things to think about. And we were able to publish that in the Neurocritical Care Society's sort of like e-newsletter. For that reason, so people could just use it as like, again, a checklist, and sort of like here was our story and here's what we went through. But yeah, I would say like 3 years ago, you probably had about 5%, 10% of stroke centers that were using T&K. And now I would say it's at least 50-50, if not leaning towards T&K use.
Are there some, clinicians or or centers or what have you that are still completely anti using T&K, and if so, like, what are their arguments for that position?
Yeah, that's a good question. I don't know if anyone's like anti it. Maybe they're anti it because here's another operational thing I was thinking about. I've kind of just been very pro T&K, that I have kind of like not really talked about Alteplase itself. Alteplase, since it is FDA approved for stroke symptoms up to 3 hours, Genentech has a program that allows you to essentially pre-mix the drug. And if you do not use the drug, they'll replace it for you, because they're, again, time is brain. But since T&K is not FDA approved, you cannot pre-mix it. However, so that may be somebody's argument, is that I can't pre-mix it. However, the fact that the reconstitution time takes like 3 minutes total, and then you push it and you're done. So that sort of seems like it's a mitigating factor. There's been some people that have been, and up until recently, there was not a ton of data of T&K use for, I would say minor strokes, stroke mimics, in case you gave it to the wrong people, like would it still cause harm? And then basically non-LVO strokes. So there were some people that were maybe having that discussion about, should we give it to all strokes? Should we just give it to LVO strokes? There's the operational considerations, the safety issues, obviously, in terms of not necessarily the drug ADEs, but the potential to cause harm with multiple formulary issues. But like overall, I don't, those are kind of weak arguments in my opinion. I think that there's plenty of data to really, and if you have a good pharmacy department to mitigate some of these things and some of these potential errors, I don't really know if there's a great argument against it. Especially coming from the same manufacturer. It's not even like you could say, oh, I like this one because I have a financial conflict of interest. They both come from the same company.
Yeah, that's a good point. No, that makes sense. And so at this point, do you feel like it's going in the direction of, centers will just keep both agents on formulary, or you think eventually it'll go to where they're using T&K, primarily?
Yeah. So, I mean, I reviewed the data for us for whether or not we were going to get rid of Alteplase for potentially, and then use T&K for catheter-directed situations, whether that be PE or even intraarterially within the brain, or cardiac arrest and PE and all that, PE. And there's just not a ton of data on PE. And I'm sure that I'm sure it's actually probably would work as good, if not maybe slightly better, with PE and those types of situations. But it's tough because I don't want to be the one to make. I would like there to be like more formal data. And actually, before we got on our call here, I like did a quick clinicaltrials.gov to see if anybody was like really looking at it. And there's a few trials on Tenecteplase for PE. So hopefully we get some of that data within the subsequent years to make that. But how the other thing I think about is like Genentech, the maker of both, really doesn't want you to get rid of. They want you to have both. So I'm sure that they'll do something to make it so that we have the opportunity to keep both. So, but if I had my druthers, if like the data was fine, I would probably get rid of Alteplase just due to the fact that the simplistic ability to just push something, especially in strained personnel models where we just do not have enough staffing.
Yeah, that part definitely makes a whole lot of sense. Is there any other agents that are being looked at in this setting as an alternative to both Alteplase and T&K?
Not that I'm like in terms of thrombolytics. No, urokinase is off the market now. Nobody uses Retaplase really. Alteplase and Tenecteplase kind of have the market cornered. In terms of stroke. The thing that's interesting now is people are looking at combination of different things. There was a recent study on the use of thrombolytics and then an argatroban infusion afterwards, just trying to prevent, potentially clot mitigation and things like that. There's a clinical trial that's looking at thrombolytics and tirofiban right now. So some of these antiplatelet agents and anticoagulation, antithrombotics together in combination with thrombolytics, which, we do that with PEs. We can give a thrombolytic and then straight into it anticoagulation. But brain tissue is a little bit different than, pulmonary and lung tissue. That it's slightly different. But no, I don't know if there's a newer thrombolytic on the market that I'm aware of. I mean, T&K we talk about it being new, but I mean, it was approved in 2000. So
yeah,
it's one of our newer ones and I'm not sure that, in terms of like our shift in stroke, a lot of our paradigm shift has been obviously with pharmacists, we're going to, get excited about the drug part, but, honestly, a lot of management has shifted towards like the use of mechanical thrombectomy to go and retrieve these clots, having mortality data, because these thrombolytics, really don't have a ton of good quality mortality data, but thrombectomy does. They have good outcomes at 6 months, and they have mortality data associated with it. So that's sort of the way to go. But certainly, these thrombolytics can act as an adjunct to a lot of these. And then potentially, if you don't have a patient that's a thrombectomy candidate, these agents may potentially have a good role in quality of life and things like that. But I haven't seen anything that's I'm aware of that maybe there's another agent out there. I mean, we have, honestly, like, you have a fairly safe agent with Tenecteplase. It works efficaciously. I mean, and you can push it. So it checks all the box. So I think we may have the ideal agent. We just need to make sure we're giving it to the appropriate patients.
Gotcha. And is thrombectomy, is that associated with like a less bleed risk or less adverse outcome in general compared to using thrombolytics?
So it just depends. Yeah, it just depends. I mean, honestly, we do both. We'll give thrombolytics and then also give what the patient will go in for thrombectomy. So that one's a little bit different, as it's kind of like when you talk about like surgical techniques, it's really technique dependent, and it really is going to be interventionalist dependent, how good they are. I don't want to like throw them under the bus because like, I'm not having to actually go in there and get it, but it's if you put the best of the best in the world, like it's certainly going to, it's just going to be dependent upon the interventionalist performing it. The other thing I think that makes a lot of difference too is the type of clot you're dealing with. And you'll read in their reports, like after they've done a thrombectomy, then they've got they've gotten a thrombolytic like TNK, they'll call it passes, basically how many times they've gone through and trying to like grab it. And sometimes you'll read that the patient, as soon as they essentially touched it, it aspirated or broke apart and completely, which to me means that it was a very loose base clot. There was maybe a little bit of fibrin that got broken down and the clot just kind of dissolved, which is perfect. That's like the kind of clot that, if you're going to have a stroke, that's perfect. That's kind of what you want, is for it to dissolve and then allow for perfusion to the area. But sometimes you read that, they touch it and it's super dense, which maybe means it's an older clot. So maybe it's coming from that left atrial appendage when we're having AFib, and sort of calcified and just like an old shitty clot that just like isn't going to really respond to the drug. And so they have to go in there and grab it. So in terms of the rate of bleeding, I mean, a good interventionalist, it can be, excellent outcomes. At that point, you really do worry about blood pressure management. And so if they're able to get the entire clot and get reperfusion all the way, sometimes they'll try to shift that blood pressure curve lower. So they'll have really tight blood pressure goals. Whereas if they're not able to get the full clot, they'll have a little bit higher blood pressure goals so that you can use that area. So a lot of those things are dependent upon the overall like outcomes of the patient.
Gotcha.
So a lot of confounders.
Gotcha. This is kind of a little bit off topic, but just, and it may be a stupid question, but you mentioned like watching for hypoglycemia kind of going into the process of giving thrombolytics, but is it something where if the patient comes in with uncontrolled diabetes in general, is there any kind of like protocol for hyperglycemia at onset?
So both. So hypoglycemia, one of the reasons we really try to assess for that is that it can act as what we call a stroke mimic. Mm-hmm. The signs and symptoms of hypoglycemia really do mimic the signs and symptoms of stroke. Hyperglycemia, you think about like the patients and there's been data on this, like higher A1C in patient stroke is associated with worse functional outcomes and potentially like bleed rates, because it goes back to inflammation of that tissue. So hyperglycemia is associated with increased inflammation, is associated with more friability of that tissue, which means that they're more susceptible to bleeding. So yeah, we certainly will look to try to keep blood glucose less than 180 milligrams per deciliter. while inpatient. And then, obviously like strict diabetes management outpatient for sure to try to prevent or secondary prevention of stroke for sure. All of that goes into place. So blood pressure, diabetes, atrial AFib management, rate agents, anticoagulation, all of that like certainly plays a key role in secondary prevention. And then obviously antiplatelets or antithrombotics together to try to prevent the clots from reforming. And certainly you could do a whole talk on like outpatient management of secondary prevention of stroke.
And I'm going to hold you to that as well. But
I'm not the expert. That's you. I'll probably come on here and ask you questions.
Right on. Well, what about as far as you mentioned antiplatelet? I know I'm kind of going past where we were intending to, but as far as like starting an antiplatelet for the outpatient setting, what's the time frame there between when you've given either agent as a thrombolytic and then when you can start the antiplatelet med?
Yeah, that's a great question too. So the sort of gold standard guideline standard is that 24 hours roughly after thrombolytic administration, you can start anticoagulation, VTE prophylaxis, and then also an antiplatelet. The other thing that we'll do is we'll get imaging, usually MRI, to ensure that there hasn't been any sort of like what we call petechial bleeds or really small bleeds, or if the patient has a very large like conversion, symptomatic intracranial hemorrhage, then obviously we won't start any of that then. But yeah, it's early on. And it used to be too, like if a patient came in that had a stroke that didn't get a thrombolytic, we would hold anticoagulation due to the fact that we thought patients would be at an increased risk for the development of basically converting into a brain bleed with anticoagulation on board. And there's actually been some newer evidence to maybe challenge that old notion that we don't really have to hold anticoagulation that long. We could probably restart it right away. There's some newer data on it. It's certainly not like certainly probably won't be in the new guideline iterations, but there's certainly some people that are challenging that. In terms of antiplatelet regimens too, like if you don't thrombolytic, there's some good data on the use of dual antiplatelet therapy for 21 days and then aspirin thereafter, which is an interesting topic in and of itself. I really think that there's been a shift too in terms of determining aspirin and P2Y12 responders for patients as well. So we've been trying to really focus on that as well when we have secondary prevention of either TIA or stroke, is looking and making sure that these patients that are receiving P2Y12s are actually responding to it. Do we need to dose increase? Do we need to dose decrease? And then, ensuring too that these patients are de-escalated or de-prescribed afterwards, that they don't need, indefinite dual antiplatelet therapy.
Right. And in this, if they are going to go dual antiplatelet in the setting of, post-stroke, are they typically still doing the 81 milligrams? Is that correct?
Correct.
Okay. Is there
81 and then...
Go ahead, sorry.
Go ahead. I was going to say 81 and then typically we'll start clopidogrel and then that'll be 5 milligrams daily. Again, that's where the pharmacists have been really instrumental at advocating for the use of functional assays to determine whether or not these patients are responding to the treatment we're giving them. Do we need to change agents? Do we need to dose escalate? There's not much benefit in terms of overall efficacy with increasing from 81 to 325 milligrams of aspirin, but you do increase bleed rates. But there may be a subset of patients that you do have to escalate because they're just not responding to 81 milligrams up front. And the same with P2Y12s. Maybe they're a clopidogrel genotype that just doesn't is not a responder with a 2C9 Is it 9 or 19?
2C9. I think it's 2. Oh my gosh, I'm second guess. I think it's 2C9.
I think it's 2C9 too, the allele. And, maybe they're not a responder, which, you read the reports, it's up to 30%, or maybe they have some sort of drug-drug interaction that we need to consider and think about.
A polymorphism to where they're not metabolizing it to activate the
correct.
Okay, I got you. I'm with you now.
Yeah, exactly. So we're able to actually functional assays to measure antiplatelet effects. And so it used to be we just throw them on it and there you go, and it kind of set it and forget it. But now we understand that these patients really need to be monitored for that response. I always equate it to, you wouldn't just throw somebody on warfarin and then not get an INR, right? So we don't need to do that with our antiplatelet regimens, and even our factor 10A inhibitors. I know they're touted as not needing monitoring, or there's really not a great therapeutic index, but I still like to obtain levels just to make sure that we're one, compliant, and then two, within sort of a quote unquote therapeutic range.
Yeah, no, that definitely makes sense. And it is 2C19, by the way. I just Googled it to make sure. Yeah, I was like, oh, great. Of course we guessed wrong.
We're both fired.
Yep, that's it.
We can edit it out. Edit that. Cut that.
No, that's too much work. I don't edit. But no, that's awesome, man. That's a great review of both agents, and I think I think that's super, super helpful. But we definitely. I don't want to take up too much of your time, because I know if I keep taking the risk of taking up your time, you're going to get a call and have to leave in the middle of it. So
yeah, fortunately, I have my resident with me tonight. He's kind of taking the reins. Yeah, he's doing everything tonight. I'm just kind of playing backup right now, which doesn't happen too often. So, but no, it's been great to come on. I mean, I could talk about this stuff all day, certainly. And when you post it on the gram, I'll try to make sure I keep an eye on the comments too, to make if anyone has any questions. And I'm sure that every student that is now a pharmacist that's taken the Naplex is like screaming at us that it's 2C19, it's 2C19.
Idiots. I can't believe you guys didn't know that. We're like, that's the word. That's my ultimate thing that drives me crazy. I mean, on one hand, I'm glad when my students, whether it's my PA students or PharmD students, will stump me, because then it helps me know where I have holes in my game. But man, and does it bother me deep down? I'll think about it for like a week. I'm like, you idiot, you don't deserve a PharmD.
Man, No. I love the consults when you send it my way. I love it.
No, man. No,
and we're like, that was crazy. We just had that text from somebody that was texting us like a year ago.
That's right. That was
had a really cool outcome.
That was awesome. Yeah, I forgot that was one of my
your students. That was really cool.
She's doing infectious disease now. And yeah, I kind of forgot about that, to be honest, because it was over a year. And they're like, patient's doing great. I was like, heck yeah.
Yeah, that was dope.
Said, we did it, aka Brian. I'm just the connector.
No, that's great. No, that's super awesome. And I just remember driving home once, like we were coming from like a 4th of July party or something, and you were like, "My students have a question." Put me on speakerphone. I was like,
they thought that was hilarious, man. Because I called you like in the middle of class, and I just had you on speakerphone, like in the classroom, and you're like, "Yeah, what do you guys want to know?" We just went over fluids.
I'm driving. Yeah, let's do it.
That was awesome. Yeah, they were all cracking up about that. But no, man,
you're
it's been great.
Guy.
Yeah, absolutely.
Know somebody,
and somebody I trust too, because I know lots of people I could ask, but I need to know I'm getting the good info. But man, we're going to definitely have to have you back on and go over like hemorrhagic stroke or something, because that would be awesome to kind of go.
Yeah,
through that process.
I mean, I certainly I can talk that and anticoagulation reversal. Those are kind of where I've ended up being my niche in the pharmacy world. Is all the coagulation stuff. So certainly that'd be awesome. I would love to get your thoughts as we move forward too on these factor 11 inhibitors. It's certainly like going to be something that I'm worried about. It keeps me up at night when I think about patients coming in bleeding. So
yeah, good old patients coming in bleeding. Always the best case.
Yeah.
Man, well,
thanks for having me, man.
Of course, man. I really, really appreciate your time, and always a pleasure to have you on. And I'm sure we'll have you on for your 10th episode, and I'm sure at some point. So keep on doing what you do, man, and we'll keep in touch and appreciate it.
Absolutely, man.
And thank you guys for listening. I hope that was enjoyable. And if you guys have any questions for Brian, make sure you hit him up on social media or LinkedIn or something like that. He's a great guy and a super, super talented pharmacist and very good educator as well. So make sure you keep tabs on him, follow him. He gets published, I feel like, every other week. So lots of good stuff coming from him. And then for those of you who want more traditional style lectures instead of the kind of me going off script on the podcast, check out Patreon. I have all the pharmacotherapy lectures that I do for my PA students, as well as the slide sets you can download and all that. So lots of good stuff over there for what I like to think is a reasonable price of like $3 a month. But if you guys have any questions for me or for Cole, make sure you email us. You can send us a text. You can hit us up on social media, whatever's convenient for you, and we'll do our best to get back to you. Thank you all so much for sticking with us and for continuing to listen. We'll see you guys in the next episode. Have a good night.